Hi guys, this is Dr. Baran Erdik with CCM Health. I am with CCM Health on a regulatory capacity, and I have been working with them all along with practice transformation and value-based healthcare. Little bit about me: I am in a healthcare compliance position, and I have seen over 4,000 incidences of allegations of non-compliance. So I am an expert on anything to do with CMS regulations and all that good stuff. So today we'll be talking about macra and MIPS, and then after the main part of the presentation, we'll be doing a deep dive on a case on how this is all scored and how to bring it all together and how to bring it home. So a couple things to understand first. So we need to be familiar with several abbreviations. So these start with macra, MIPS, FFS, PCMH, and NCQA. So macra is the Medicare Access and Chip Reauthorization Act of 2015. Basically, it replaced the 1997 Sustainable Growth Rate Formula for determining Medicare reimbursement. Provides a new approach to Medicare reimbursement based on value and quality. If you all remember, back in the good old days, you saw a patient, you billed for it, you were done. Ultimately, what has been happening is that with macra and then ultimately the two separate but related payment pathways it created, the MIPS and the advanced alternative payment models. Now the quality of that service you provided comes into play, as well as other things like preventative services, how much you spent, and so on and so forth. Ultimately, with regards to 6 different goals, which are to improve the patient outcomes, enhance the clinician experience, increase advanced APMS, promote program understanding, improve data and information sharing, and ensuring operational excellence. From a PCMH perspective, PCMH is a advanced alternative payment model. So it's an accreditation, and we do provide guidance for that in CCM Health as well. And be sure to check out my other webinar on PCMH. And NCQA is the body that accredits PCMH mainly. There's other bodies, but NCQA is the main one. So as we said, this macra combined 3 legacy programs and then ultimately gave you MIPS. So you may be one of those people that don't bill enough, that don't do enough CMS business. That means that you will be exempt if you're a first-year participant in Medicare Part B. If you're low volume, less than 90,000 or 200 patients, you may opt in, but you're not automatically enrolled, and ultimately that means that you don't have to participate. Or if you're participating in an advanced alternative payment model, AAPM, then at that point you can also opt out. So why is this important? Because anything to do with government, everything is ultimately tied to money. So there's a carrot and stick approach here. If you do good, you can get up to 9%. If you do bad, you can get the 9% penalty. This was designed to be budget neutral. That means there's also more upwards adjustments for these 9% or 7% or whatever. And then depending on how other people are doing. So what CMS expected was that if you were a big fish, you were going to do fine. If you were solo or if you were 2 to 9 clinicians, you were relatively going to lose. There's a bunch of issues with this and a bunch of reasoning behind this. But at the end of the day, this is the sad reality, right? So if you are a smaller practice, you need to be more mindful of how you're going to ensure you're going to be a winner in this MIPS payment system. So if you look at the projections, about every common specialty like internal medicine, family practice, cardiology, whatever, they have about a 40-60 split. So about 40% of the clinics or the specialists are going to be looking down a negative payment adjustment, and then 60% are going to be looking for a positive payment adjustment. So again, that means that especially if you're a smaller clinic, you need to be more mindful of what you're doing. But what is MIPS? So MIPS is a final score that tells CMS how you've been doing. Consists of 4 things. These are quality, cost, clinical improvement, and advancing care information, which we'll discuss all of these in a second. So one note, as you can see from the beginning, the rate of quality has been going down and cost has been going up. For 2022, they are about equal. Clinical improvement and advanced care information have been about the same. So quality. Quality is 40% of your final MIPS score. There's 209 quality measures. These are changed yearly. There may be more or less depending on the year. You need to select 6, one of which has to be an outcome measure or a high priority measure. These are scored from 0 to 10 points. You get bonus points for outcome, patient experience, and high priority measures. If you're a small practice, you get a 6-point bonus. And each measure submitted using electronic reporting is an additional 1-point bonus. So some examples. For example, diabetes, hemoglobin A1C, poor control. What percent of your patients had HbA1c levels more than 9%? Or say CAD, coronary artery disease. If they have LV systolic dysfunction, their ejection fraction is less than 40%. Are they on beta blockers? So ultimately, these are all about, are you managing your patient population good? Are they on appropriate preventive measures? And are you providing care that is in scope with most evidence-based guidelines? And ultimately, the goal is that an ounce of prevention is worth a pound of cure. How do we maximize this? So basically, we need to target measures with lower benchmarks. What does it mean? You are being compared to other providers. There is no established set benchmarks, meaning you as Dr. Amazon is being compared to Dr. DHL or Dr. Lemon. So everyone is in a fish tank and CMS is bidding people against each other. So if people are doing bad, you're doing good, good job. Everyone's doing good, I mean, good job to everyone, but if someone tends to do bad, good luck to them. So basically, you can see what approximate benchmarks were for the last year submitted that they made available. You can take it from there. You need to make sure that everything's reported. At least you'll get the bonus points, regardless if it's counted or not, regardless if your patients did bad, did good. At least if you report, you'll get some bonus points, hopefully. And then, I mean, if you're a cardiologist, there's no point in using a pediatric data set, right? So there's no point in using a pediatric quality set saying, oh, patients under 18 were given the influenza vaccine. So use the specialty sets when possible. Those will be the most relevant to you. How about cost? So cost is an interesting one because you don't do anything. It's reported automatically by CMS. It's automatically calculated. So they retrieve the cost data from administrative claims. They look at total cost per capita for attributed beneficiaries, Medicare spend per beneficiary clinician, and then ultimately telehealth is now in this. So think about it this way. If you're doing good with prevention, your patients are most likely not being hospitalized in the ER, so you're doing good cost-wise. But if you're someone that doesn't do preventive care well, your patients go to the ER or you order a bunch of unnecessary tests, then you're unlikely to do really good here. How about clinical practice improvement? So basically, the goal of this is to have clinicians render care that is focused on care coordination, beneficiary engagement, and patient safety. In 2021, there's 105 improvement activities. Medium weights are worth 10 points, high weights are worth 20. You max out at 40. So you can do 4 medium weights, 2 high-res, or any mix. You basically attest yes, and you get full credit if you're a PCMH. One caveat, there's a lot of audits going on, so please, please, please do not ever attest yes unless you're actively doing it. So if you attest yes, the onus is on you to prove that you're doing it, and you better have good documentation of what has been done for that improvement activity. For promoting interoperability, it is asked that you need to use a certified EHR technology. Ultimately, there's 4 goals: the e-prescribing, health information exchange, provider to patient exchange, public health and clinical data exchange. And basically, this was changed from an all or nothing EHR incentive. And there's reduced reporting requirements to public health registries, but this is bound to change, especially in light of the public health emergency and the data required with regards to COVID, may be vaccinations or comorbidities or whatever. Ultimately, this is base for 60. If you report 1 use case for each, you can report more and you get 10 per, and you're capped at 100 points. So let's discuss how people are doing for a second. So as you can imagine, the mean score has gone down, and with the pandemic, it's become a tad more unpredictable, which we'll see soon, because CMS releases data 2 years after the fact. So mean has gone down, median has gone down as well. So especially from a small practice perspective, that median has gone down even more. So there's a tendency to congregate down at a lower score, basically. So people are not necessarily doing good. Of note, if you're doing more than 85 points in 2021, you'll have a positive adjustment. 60 to 85, possible positive. 60 is neutral. Anything less, you're losing money. Anything below 15, you're -9. Ultimately, where's the competition in those who participate and who engage? If you're engaging, you're doing better. If you're participating, you're doing worse. So you may already be participating without actually engaging. So you need to start engaging. Basically, it's like you're running a race without knowing you're running a race. So if you at least know you're running the race, you'll try harder. So what are the potential issues with MIPS? I mean, there is no absolute standards, right? So if you ask me, oh, Dr. Erdik, what are we supposed to do? What score should we aim for? I can't tell you anything, because the judgment is made 2 years after the fact and depends on how other people are doing. So it's a moving target. Everyone's doing really good. If you perform at 95%, you may still be several standard deviations down. So you may get a permanent penalty for a grade A care, right? 95% is really good, but you may get a penalty. And ultimately, the big fish effect, the Kaiser Permanente effect, right? So if it's a big enough bureaucracy, they will find methods to meet the standards without actually achieving the goal, which is excellence in care. So ultimately, a big enough bureaucracy will have dedicated people, dedicated data sets, everything to work the system to wherever they want to work it. So ultimately, the crux of being a grade A student is through chronic care management. Chronic care management covers 33 measures under quality, 22 of which are high priority. So it fulfills clinical practice improvement, addresses cost resource use, advancing care information, all of these through EHR as well. And since 2015, CMS has reimbursed chronic care management for non-direct care under different CPT codes. Granted, the patient has chronic issues, and then these services take at least 20 minutes. You may be like, oh, my patients don't have chronic issues. This is a quote from my favorite book that got me through medical school, that elderly patients have at least 6 diagnosable disorders on average. So you may not know all of them, but they are there. So in order to build chronic care management, You need to provide people access to care management services that are 24 hours a day, 7 days a week. So at least some sort of phone line, some sort of emergency line to reach them without directly going to the ER. You need to have a individualized patient-centered care plan, and then the coordination and transitions in care between settings are needed. But now the good thing, CMS does allow for chronic care management to be outsourced. How about APMs? So APMs are not subject to MIPS. They receive a lump sum 5% bonus and a higher fee schedule onwards. There's different ones depending on their specialty. You may have an oncology care model, cardiac care model, or PCMH. And for PCMH, I invite you all to watch my webinar that is dedicated to PCMH. So ultimately, before we move on to case and do a deep dive, you're already being scored, right? Unless you meet the exclusion criteria, so you need to take action now before another year is spent and people are getting better at MIPS, getting better at scoring, and you're looking forward to losing even more money. We are going to do a deep dive into a MIPS case, and I'm going to try and break down how this is all scored and how it all comes together. So ultimately, MIPS, as we discussed, is made out of quality, resource use, advanced care information, and practice improvements. So the weights have been changing, and for 2021, we're looking at 35, 25, 15, and 25. Well, okay, never mind. So ultimately, points for each of these are dependent on publications from 2 years ago. So basically, you get a point based on deciles. So let's say a quality measure where people are doing good, and it's from 0 to 100%. So if you do 60, you'd be in like decile 6. So you'd get the decile 6 points. So minimum point is 1. And then ultimately, from a quality component, the total measure points plus bonus over possible points. So these deciles and the percent cutoffs are released every year, but they're based on the data from 2 years ago. Then you look on the composite score. So basically everything times the weight of it gives you the composite score. And ultimately, you are judged based on that composite score. If you don't report, you're automatically getting a 0, right? So why would you not? So let's look at this provider, for example. They've scored only a 3 for quality. So the weighted score is 3. They would be getting a 50 for CPIA, 50 for advanced care, but there's nothing for resource use. So they didn't get it because they probably didn't report it. So they're getting 23 points. If they were to submit for quality, they are still getting a 0 for resource use. For whatever reason, CMS didn't report, doesn't matter. But ultimately, they're getting up to 53.5. So do report, even if you're doing mediocrely. You're going to get a much better score. So for quality, you do need one outcome or a high importance measure. So you need to at least report 6 on at least 90% of the patients. It used to be 50. Some of you may still be doing 50, but it's now 90. Similar to PQRS. So basically, you need to look at your annual QR/UR report. This is a sample I found. So CMS auto-calculates moving in the direction of episodes versus fee for service. I mean, you're trying to be high quality and local. So the goal is right upper quadrant, right? So the better you do, the higher you'll be scored, basically. You don't want to be left low. You don't want to be, I guess, left high or right low, but the goal is to be right high. How about advancing care information? So basically, just an improvement on meaningful use. Are you e-prescribing? Are you doing a security risk analysis, patient EHR? Are you doing your care summaries electronically? To get a base score of 50, you need to test. You need to get a full credit. You can use the HHS SRI tool to prove compliance and attestation. And I said the onus is on you to ensure that you're compliant. The onus is on you to ensure that when you're audited, you have the necessary paperwork to show that you're compliant. For CPIA, this is more primary care focused. Ultimately, you need to have expanded access, population management, health equity, emergency preparedness. But again, easy to get max points. You test, you report, you audit, you document. But if you're not a primary care, you may be like, which ones am I going to do? I mean, you can still try and extend to have patient safety, have beneficiary engagement, have emergency preparedness, and maybe even expand access, right? You may be like, oh, I'm an orthopedist. I don't need to expand access. I mean, you do. What is that person got to do if they twisted their ankle? Just go to the ER, or if you had some sort of after-hours phone line, at least maybe they can call your office, schedule something for the first thing in the morning, sort of. So it's doable. You just need to think outside of the box. So what can we do here at CCM Health for you? So we need to educate, estimate, determine, optimize, evaluate, plan, monitor, identify, and report, and this will all equal to monetary savings for you. So we can help educate your staff, estimate the impact of these, optimize your care, optimize your clinic, optimize your workflow. Ultimately, we can also evaluate and plan for chronic care management, monitor what's been happening, identify any gaps in these issues, and report back. And ultimately, this will all equal to a high MIPS score, not just high MIPS score, but savings. And ultimately, this will be equaling more money for your practice, more money for your clinic. So thank you for listening to my webinar. Be sure to follow CCM Health on YouTube, on LinkedIn, and all that good social media stuff. And I look forward to seeing you guys on my next webinar.